Hello, everyone, and welcome to our module on systolic and diastolic heart failure. So when we say a patient has heart failure, we usually mean that there is failure of the left ventricle to function properly. There are rare forms of heart failure that involve only the right ventricle, but those are uncommon. And usually when we say someone has heart failure, we mean that their left ventricle, which is the chamber right here in this slide, is not functioning properly. So in the video on heart failure basics, I talk about how we usually make the diagnosis of heart failure based on clinical findings. If a patient has the typical signs and symptoms of heart failure, then we say they have the clinical syndrome of heart failure. But when we do echocardiograms and look at the hearts of patients with heart failure, we can divide them into two groups: patients who have what's known as systolic heart failure and patients who have what's known as diastolic heart failure. This patient on the left here has systolic heart failure. You wouldn't know this if you're not trained to read echocardiograms, but this patient has a very low left ventricular ejection fraction, probably about 10%, and normal is over 55%. So if this patient on the left had the clinical syndrome of heart failure in this echocardiogram with a reduced ejection fraction, we would say that patient has systolic heart failure. On the other hand, this echocardiogram from the right is also a patient who has clinical findings of heart failure, but you can see the ejection fraction is normal. This person's ejection fraction is about 60%. So in this patient, because the ejection fraction is normal, we would say they have diastolic heart failure. In both forms of heart failure, systolic and diastolic, you can have the same congestive signs and symptoms. So patients with both forms of heart failure will complain of dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. And on physical exam in both forms of heart failure, you can identify rales, elevated JVP, and pitting edema. So the presence or absence of these symptoms does not help you distinguish between systolic and diastolic heart failure. The one exception is low flow symptoms, which I talk about in the video on heart failure basics. These symptoms occur only in systolic heart failure and only when the left ventricular ejection fraction is very, very low and the cardiac output is very, very low. These patients can develop cool extremities, cachexia, and confusion. These are all due to very low cardiac output, and you only see those in systolic heart failure. You will sometimes hear the term dilated cardiomyopathy used when talking about patients with heart failure, and this term essentially means systolic heart failure with LV cavity dilation. So patients with a dilated cardiomyopathy have a reduced left ventricular ejection fraction, just like all systolic heart failure patients, and also when you measure the size of their left ventricle, the cavity is dilated or stretched. In the video on blood flow mechanics, I talk about different forms of left ventricular hypertrophy. And you should know that patients with a dilated cardiomyopathy have the eccentric form of left ventricular hypertrophy. So in the eccentric form of hypertrophy, there's volume overload of the left ventricle. In other words, because the left ventricle is failing, there's chronic retention of fluid in the cavity and a high volume of blood. This stretches the myocytes of the left ventricle so they become longer, and over time they adapt by adding sarcomeres in series. So in patients with a dilated cardiomyopathy and eccentric hypertrophy, they go from something like this to something like this, where the cavity is dilated, the myocytes are stretched, and sarcomeres have been added in series like this so that they can reach all the way around the dilated cavity. And I've summarized these findings here. There's increased myocyte size in eccentric hypertrophy, sarcomeres are added in series, and importantly, the wall thickness is not increased. So the width of this wall right here is not increased compared to normal in a patient who has eccentric hypertrophy. Contrast that with concentric hypertrophy of the left ventricle. This is what happens when there's pressure overload, when there's chronically elevated pressure, markedly elevated pressure in the left ventricle. This usually occurs in patients who have long-standing severe hypertension or aortic stenosis. That's what usually leads to this form of hypertrophy. So what happens in this form of hypertrophy is you go from a normal ventricle to one where the walls are very thick like this. This is concentric hypertrophy, and there's a decrease in the size of the left ventricular cavity. This happens because sarcomeres are added in parallel, not in series, and this makes the wall thicker. When the wall gets thick like this causes decreased compliance, a stiff left ventricle, and therefore these patients often develop diastolic heart failure because the underlying problem in diastolic heart failure is lack of compliance and a stiff ventricle. Let's talk about some other differences between systolic and diastolic heart failure. So in the video on pressure volume loops, I talk about this line right here, this dashed blue line, which is the end systolic pressure volume relationship. In a patient who has systolic heart failure, the primary problem is a decrease in contractility of the left ventricle. That moves this line like this over to the red dashed line, and that changes the pressure volume loop from the blue loop here to the red loop here. In contrast, in diastolic heart failure, the primary problem is a decrease in left ventricular compliance. Basically, the left ventricle does not relax normally, it's stiff. And relaxation of the left ventricle is called lusitropy, and so there's a decrease in the lusitropy of the left ventricle, and therefore the compliance in diastolic heart failure. That moves this line right here, which is the end diastolic pressure volume relationship. It moves from here to here in patients who have diastolic heart failure, and that changes the pressure volume loop from the blue one here to the red one here. Let's talk in a little bit more detail about systolic heart failure. So in systolic heart failure, there's a fall in cardiac output. And the reason this happens is because there's a problem with systole. That's why it's called systolic heart failure. There's a decrease in contractility. The left ventricle is not squeezing normally, so it can't get the blood out normally into the aorta. This leads to a fall in the stroke volume. Each time the left ventricle squeezes, there's less blood pushed out compared to normal in systolic heart failure. That's a fall in stroke volume. Remember that the stroke volume is the difference between the end diastolic volume and the end systolic volume. The end diastolic volume is the volume at the end of diastole when the left ventricle is the most filled with blood, and the end systolic volume is the volume at the end of systole when the left ventricle has pushed out as much blood as it can. The difference between those two volumes is the stroke volume. The major change in systolic heart failure is that the end systolic volume goes way up from the fall in contractility. Because the ventricle can't squeeze normally, it can't push blood out normally. So at the end of systole, there's a lot more volume of blood left inside the heart. And this big rise in the end systolic volume here is what causes the stroke volume to fall. You also see some increase in the end diastolic volume, although it's less. The end diastolic volume is equal to the end systolic volume plus the blood that fills the left ventricle as venous return. So when this end systolic volume goes up, you are going to get some rise in the EDV, but the major rise is in the end systolic volume, and that's what makes the stroke volume fall. Also in systolic heart failure, there's a rise in the left ventricular end diastolic pressure. So there's going to be more blood inside the heart at the end of diastole because the heart is having trouble getting blood out into the aorta. So with more blood in the chamber at the end of diastole, there's more fluid pushing against the walls of the ventricle, and that's going to lead to a rise in the LVEDP. And all these things I've listed here are super high yield to know for step 1. These are the types of things they like to ask you about heart failure patients. And then once again, I've shown 2 pressure volume loops on this slide. This is a normal one, and this is a patient with systolic heart failure. The major change is that this dashed green line has moved in this direction, and that has caused the pressure volume loop to become narrower, which means that there is less stroke volume. In the video on the Frank-Starling curve, I talk about how changes in contractility shift the Frank-Starling curve like this, and you should be aware that that is what happens in patients who have systolic heart failure. This change depicted on this slide is the classic change that illustrates what happens to the heart when it develops systolic heart failure. Now let's talk about diastolic heart failure. So in diastolic heart failure, there's also a fall in cardiac output, but it's usually much less than the fall that you see in systolic heart failure. And in diastolic heart failure, the problem is in diastole. That's how it gets its name. The ventricle is stiff, and therefore blood doesn't fill it normally. And so when it doesn't fill normally, there's less blood in the chamber, and therefore less blood goes out as cardiac output. There's a small decrease in stroke volume in diastolic heart failure. This occurs because the end diastolic volume is slightly decreased because the ventricle can't fill because it's stiff. But the major hemodynamic change in diastolic heart failure, and the one that it's most important for you to know, is that the LVEDP rises a lot. And that's because the ventricle is very stiff, so the pressure on the blood inside the left ventricle at the end of diastole, when the chamber is maximally filled, is going to get very, very high. And this is really the hallmark and the main problem of diastolic heart failure. It's not so much the low cardiac output, it's the very high LVEDP. And so once again on this slide, I've shown 2 pressure volume loops. This is a normal one here. This is a patient with diastolic heart failure. The major change is that this line moves in this direction, which is what I've depicted here. It causes a slight decrease in the width of the pressure volume loop. That means there's a slight small in stroke volume. But the major change is that the pressure at the end of diastole, which in the normal patient is down here, rises to a higher level in the patient with diastolic heart failure. That's that LV pressure, and it goes up in patients with diastolic heart failure. And once again, I've summarized the underlying problem of diastolic heart failure. That's a fall in compliance and a decrease in lusitropy. Let's talk in a little bit more detail about how the volumes in the left ventricle can change in systolic versus diastolic heart failure. So in this table, I've shown you some hypothetical volumes in milliliters that you might see in a normal heart versus a heart with systolic heart failure or a heart with diastolic heart failure. Let's look at the normal heart first. So suppose the normal heart has an end diastolic volume of 100 milliliters and an end systolic volume of 40 milliliters. Well, the stroke volume is the difference between those two numbers, so that would be 60. And the ejection fraction is the stroke volume divided by the EDV, so that would also be 60. And make sure you understand how I got these two numbers from the first two up here. In the patient who has systolic heart failure and a dilated left ventricle, there's going to be more volume inside the left ventricle. So the EDV could double up to 200, and the ventricle is failing, so it can't push a lot of that blood out. So at the end of systole, there's 160 milliliters left inside it, also a big increase compared to normal. When you do the math, this gives you a stroke volume of 40 and an ejection fraction of 20%. And so these are the type of numbers compared to normal that you would see in systolic heart failure. In diastolic heart failure, at the end of diastole, we have a volume of 90. That's a little bit lower than the normal patient, and that's because the ventricle is stiff and it can't fill. When the ventricle squeezes, it's still able to push out enough blood to get down to 40 milliliters at the end of systole. But when you do the math, this gives you a stroke volume of 50, so it's slightly decreased compared to normal. And as I said, in diastolic heart failure, there's a small fall in stroke volume or cardiac output. And then when you work out the ejection fraction, it comes out to 56%, which is within the normal range of above 55. So this is what you can see in diastolic heart failure: a normal ejection fraction, a slightly reduced stroke volume, and the main change is that at the end of diastole, there's less blood, and that's because the chamber is stiff and can't fill. Systolic heart failure is sometimes called HFrEF. It gets its name because HFrEF stands for heart failure with reduced ejection fraction. On the wards, you'll hear people using this term. And the most common cause of systolic heart failure is myocardial infarction. When there's a myocardial infarction, myocytes are replaced by scar tissue, which does not contract, and that reduces the left ventricular ejection fraction. And when patients have a decreased ejection fraction caused by myocardial infarction, we say that they have an ischemic cardiomyopathy. There are also many causes of non-ischemic cardiomyopathy, although these are less common than myocardial infarction. About 50% of the non-ischemic cases of cardiomyopathy are idiopathic, but there are many other causes, including all these things listed here, and I'll talk about each of these in the next few slides in just a minute. In contrast to systolic heart failure, where we have all these established causes, the exact cause of diastolic heart failure is unknown. We basically don't know why patients develop this, although usually it occurs in patients who are older with other comorbidities. Most cases of diastolic heart failure have concentric hypertrophy, like I mentioned before, and most cases are associated with older age, diabetes, or hypertension. And diastolic heart failure goes by a whole bunch of different names. I'll tell you these now just so you've heard them. One is heart failure with preserved ejection fraction, or HFpEF. The other is simply diastolic dysfunction. So I'll finish this video by going through a handful of causes of non-ischemic cardiomyopathy. These are all conditions that can lead to reduced ejection fraction and systolic heart failure. And the first one I'll talk about is viral. So viruses can infect the heart and cause a cardiomyopathy and systolic heart failure. Usually this occurs in patients following an upper respiratory infection. It's believed that the URI progresses and the virus gets into the heart. There are many viruses that have been associated with non-ischemic cardiomyopathy. Coxsackie virus is the classic one, but others like influenza and adenovirus have also been described. As I said, it's believed that the virus enters myocytes and that causes the systolic heart failure. This causes inflammation and myocarditis, and that leads to cardiomyopathy. Often the myocarditis phase is asymptomatic and goes undiagnosed, so the first clue you get that the patient has a non-ischemic cardiomyopathy is when they have a URI, and then a few days or weeks later, they develop the clinical syndrome of heart failure. And we treat this just like any form of systolic heart failure. Usually there's no specific therapy for the virus that's required. Peripartum cardiomyopathy is a form of systolic heart failure that occurs late in pregnancy or early in post-pregnancy after the baby's been delivered. The exact cause is unknown. It's likely multifactorial. And women who develop this condition are often advised to avoid future pregnancies because there's a risk that the heart failure could get more severe with a subsequent pregnancy after the one that caused the cardiomyopathy in the first place. There are some chemotherapy drugs used to treat cancer that can cause cardiomyopathy and systolic heart failure. Usually it's the anthracycline drugs, which I talk about in detail in videos in the hematology section. These are anti-tumor antibiotics. These are drugs like doxorubicin or daunorubicin. And so in patients given these drugs, usually they have frequent echocardiograms to monitor their left ventricular function and make sure they're not starting to develop a cardiomyopathy. There are familial forms of cardiomyopathy that run in families and are caused by genetic mutations. Often these are mutations in genes that code for sarcomere proteins. For example, there have been families described with mutations in the genes that code for beta-myosin heavy chain or alpha-myosin heavy chain and also troponin, although there are many other sarcomere proteins that have been implicated. Lots of these disorders are autosomal dominant, but there are also X-linked and autosomal recessive forms described. So on your board exams, it's unlikely they're going to expect you to know the inheritance pattern of a familial cardiomyopathy. In the video on atrial fibrillation, I talk about tachycardia-mediated cardiomyopathy. So if patients have an arrhythmia like atrial fibrillation and they have a constant rapid heart rate for weeks or months, this will lead to depression of their LV systolic function and they can develop systolic heart failure. Importantly, this is usually reversible if you slow the heart rate or restore normal sinus rhythm. So it's important to identify when a tachycardia has caused a cardiomyopathy because this is very easy to reverse if you simply treat the underlying tachycardia. Another form of non-ischemic cardiomyopathy is called Takotsubo cardiomyopathy. It also goes by the name of apical ballooning. This is a stress-induced form of cardiomyopathy. It's brought on by severe emotional distress. Often it's the death of a loved one. I've seen it in patients who had the death of a pet, but there are many, many severe emotional distressors that have been described as leading to this cardiomyopathy. When the cardiomyopathy develops, it leads to a markedly reduced left ventricular ejection fraction. Also, if you measure the cardiac enzyme levels like CK and B and troponin, they will be elevated. And there can be EKG changes, often ST elevations, that look like an anterior myocardial infarction. But when you do an angiogram, there's no coronary disease. So the way this usually presents is someone has a recent severe emotional distress. They develop chest pain and shortness of breath. They're usually thought to be having a myocardial infarction, but when they go to the cath lab, their coronary arteries are clean, and then they're diagnosed with stress-induced cardiomyopathy. And usually this recovers in about 4 to 6 weeks. It's usually a temporary form of cardiomyopathy. And in case you're wondering, Takotsubo, that name comes from a Japanese octopus trap, which resembles the shape that the left ventricle takes in this condition. So if you look at this image on the slide here, when the ventricle squeezes in systole like this, the apex, which is this portion right here, balloons outward. That's why it's called apical ballooning cardiomyopathy. And this funny shape that I've just drawn with my white pen here looks like a Japanese octopus trap called a Takotsubo, and that's why this is called Takotsubo cardiomyopathy. Alcohol is another potential cause of non-ischemic cardiomyopathy. Chronic consumption can damage the heart. This is believed to be due to toxic metabolites, although we don't know exactly why. Alcohol causes cardiomyopathy in some people, but not in others. And usually the left ventricle can recover if the patient stops drinking. So in any patient you see in the hospital with new onset heart failure and systolic dysfunction, always want to ask how much alcohol they drink, because if they are drinking a lot and they stop, their heart will often get better. All right, and then I'll finish this video with a very rare form of heart failure that's completely different from systolic and diastolic heart failure, and that's called high output heart failure. So high output heart failure occurs when the heart is in overdrive and it's beating very fast and contracting very vigorously. You can see this in patients who have severe anemia. You can also see this in patients who are hyperthyroid. It's also been described in patients who have vitamin B1 or thiamine deficiency. This is a condition called beriberi, and it can lead to high output heart failure. You can also sometimes see it in patients who have AV fistulas post-surgically. So if there's damage to the arteries and the veins and a connection develops connecting the arterial system to the venous system, this can lead to high output heart failure. The exact mechanism by which the heart failure develops is unclear, but it's thought to be that the heart is beating so fast that there's not enough time for the left ventricle to fill, and therefore you get high pressures in the left atrium and all the high pressures that we usually see in systolic or diastolic heart failure. But what makes this form of heart failure unique is that the cardiac output is high. Remember what I told you before, cardiac output is usually low in all forms of heart failure, systolic and diastolic. This is an exception where the cardiac output is high. So these patients have all the heart failure symptoms you would expect, like dyspnea and pulmonary edema and lower extremity edema, but they have absence of a low cardiac output. If you measure their left atrial pressure, it will be high, but once again, the cardiac output is not low, it's high. And other things like elevated JBP and pulmonary edema can also be present. But once again, the defining feature is a high cardiac output. So this is a very rare condition, but for your boards, you want to remember that if a patient has one of these conditions and they have the clinical syndrome of heart failure, they could have high output heart failure, where all the findings are the same as in other forms of heart failure, except the cardiac output is high. And that concludes our module on systolic and diastolic heart failure.